to all presenters. So here we go with the first presentation, Dr. Sivagami. She is pursuing her secondary DNB from the Government Hospital Pondicherry, and she'll be talking on vacuum-assisted cortex removal. So all to you.
A very good evening to one and all present here. As concerned with cortex removal, I am here to present about a device, VCR, that is vacuum-assisted cortex removal, which is aimed at not replacing the time-tested Simcoe cannula, but to look at the opportunities for improving the ease.
Your screen is not sharing, Sivagami.
Yes, ma'am.
You have to share screen. Yes.
This device is aimed at not replacing the time-tested Simcoe cannula, but look at the opportunities for improving the ease, sophistication, and performance. So we intend to highlight the low-cost addition to the traditional Simcoe, which can provide greater volume of effective aspiration, a non-fluctuant vacuum, and operating with a free non-dominant hand. So here we move on to the video.
Vacuum-assisted cortex removal. Concerned to manual small incision cataract surgery, the legacy of Simcoe cannula will leave a remarkable footprint in the sands of time, despite the need to flush repeatedly and also retain a constant pull over the plunger of the syringe, which is indeed a physical strain in addition to stress to do a safe surgery. The need for repeated flushing due to inadequate volume of aspiration and the high variable vacuum relying entirely on manual pull is very fluctuant and completely dependent on the surgeon, which in case of beginners can even cause posterior capsular rent. We all are aware of the syringe with spring action used in femto surgeries to build up the pressure and stabilize the globe, which had also set the stage for safe device, spring action apparatus for fixation of eyeball. We got into action and experimented it. Unfortunately, to our disappointment, the reality while using a thin coiled spring on a 5cc syringe inside the eye's anterior chamber did not meet our expectations. On analyzing, we could attribute the failure to the spring's lesser recoiling capacity and lesser volume of effective aspiration. However, with persistence and determination, we tried with a range of springs of varying coil thickness and varying number of coils. Eventually, when inadequate volume was the only concern, we jumped in and started trials with a 10cc syringe. After a lot of analysis, we ended up with an appropriate diameter thin caliber coiled spring with approximately 11 coils, producing just the adequate pressure, and named it VCR, Vacuum Assisted Cortex Removal. The plunger and barrel of a 10cc syringe are first disassembled. The coiled spring is inserted on the plunger and the syringe is assembled. Spring in a state of compression, the Simcoe cannula is introduced into the anterior chamber and the thumb slowly releases the pressure on the flange of the plunger. The release of spring creates vacuum that allows the cortical material to fill the port, which is then manually stripped off its attachments and hence aspirated. The initial phase has a controlled but dynamic vacuum which gradually decreases during the later phases, leading to slower aspiration. With practice, one will be able to self-determine the amount of spring compression that achieves adequate cortical displacement. We can manipulate the rate of aspiration by keeping a hold on the flange, limiting the relaxation of the spring. The controlled vacuum produced by VCR avoids any sudden aspiration of ocular tissue as with traditional Simcoe and hence minimizes the risk of posterior capsular rent. Also, any inadvertently caught iris tissue or posterior capsule can readily be flushed out. Retaining a minimal amount of air in the syringe while entering the AC will serve the same purpose. Gradual and gentle vacuum gives us the liberty to hold the syringe freely in left hand and concentrate on cortical aspiration, making it more advantageous. Also, the larger volume of effective aspiration helps complete cortical cleanup in one go without the need to repeatedly flush out the aspirated contents. VCR fulfills all the criteria for an ideal device. Change does not change tradition, it strengthens it. It is an opportunity and not a threat. Likewise, VCR is an economical, effective and novel change to the tradition and a small step forward towards comfort and safety.
Thank you, Dr. Sivagami.
Thank
So,
you, sir.
judges, all for you.
I think it was an excellent presentation by Sivagami. Huh? Assistance pays. Huh?
Yes, it was really good, Dr. Shivagami. Of course, needs to be tried to understand how extremely smooth and consistent it is, but very well presented.
Thank you, ma'am.
Gaurav?
Sivagami, I have a question.
Dr. Sivagami, I think it was very nicely done and, very simple yet very innovative, thing. Only thing, two questions come to my mind. One was on the gauge, like, things will change, if you have a 10cc syringe and, the cannula's aspiration port, can be different between different cannulas. So one question would be that. And the second would be that from what I remember from my ECC days, between the 5cc and the 10cc syringe, we used to somehow find the 5cc more, predictable, and the 10cc would have more unpredictable behavior. So while you've obviously done all your trials, but, between different hands, would it matter that, different size of syringe and different ports on the cannulas so that, a beginner may not struggle like that?
Sir, we have actually tried in around 10 experienced surgeons in around 45 cases, sir. I think it requires a little bit of wet lab practice before we can go ahead and try with the beginners. And about the 10cc, when we tried with the 5cc, we had difficulty because the spring